Let's proceed to your intraoperative period. When we say intraoperative period, this the period wherein the surgery or the procedure now takes place. So, meron pa rin tayong nursing management during this period. Let's first meet our surgical team. In this slide, our patient, siya yung inooperahan. Then we have our circulating nurse or circulator. Baka siya yung nanguha ng picture because the the circulator is considered as non-sterile. Now for the scrub roll, dito sa slide kasi is dalawa sila na naka-scrub. We have our first scrub nurse and the instrument nurse. Then we also have our registered nurse assistant, first assist na tinatawag natin. And then the surgeon. Tapos yung anesthesiologist or anesthetist, kilala mo siya kasi lagi siyang nasa may head part ng patient. And then we also have our OR technicians. They are the one responsible for the equipments and materials sa may OR pag nagma-malfunction or not. Now, this surgical team, ito ang general component ng ating surgical team. Pero pag ang institution mo or ang hospital mo is a learning institution, mas marami pa dyan. It includes your surgeon, 2 residents, isang intern, isang clerk, you have your staff nurse, scrub and circulating. Then we will also have your student nurse, scrub and circulating also. Anesthesiologists, resident anesthesiologists, nurse anesthetists, OR technician, and the clinical instructor. So, sa isang OR room lang yan. So, pwedeng it would consist a 7 to 14 na team sa isang OR room. For the roles and functions of the circulating and the scrub nurse, you have a separate handout for this. Please read it. Ang i-emphasize ko lang is yung instrument and your sponge counting. So, ginagawa yon 3 times. We have our initial count during the surgery and before the closing of your incision. So, ano yung script doon? Sasabihin mo muna yung name ng surgeon, susunod yung anesthesiologist, plus the name of the nurses na involved. So, ganito yon. Doc A, Doc B, Ma'am assists, all instrument, including sharps, needles, and sponges, are counted completely. Dapat malinaw mong sinasabi yon at naririnig nilang lahat para ma-ensure that it is really a complete count. The surgical environment. Now, to help decrease microbes, the surgical area is divided into your 3 zones. The unrestricted zone, it is where the street clothes are allowed. The semi-restricted zone is where attire consists of your scrub clothes and caps. And the restricted zone, it is where your scrub clothes, shoe covers, caps, and masks are worn. The surgeons and other surgical team members wear your additional sterile clothing and protective devices during the operation. Mas makikita nyo yun sa virtual tour video nyo, yung mga demarcation lines and also kung nasaan yung unrestricted, restricted, and your semi-restricted. Principles of your surgical asepsis. Number 1, all articles used in an operation have been sterilized previously. So, all articles has to be autoclaved and all sharps has to be soaked in a soaking solution. Pwedeng Sidex, pwedeng Steranus. Second, persons who are sterile touch only sterile articles and persons who are not sterile do not touch sterile articles. Third, if in doubt of the sterility of anything, consider it not sterile. Fourth, non-sterile person, avoid reaching over a sterile field. Sterile person, avoid leaning over a non-sterile area. Fifth, tables are sterile at table level. 6. Gowns are considered sterile only from waist to shoulder level, in front and the sleeve. 7. The edge of anything that encloses sterile contents is not considered sterile. 8. Sterile person keep well within the sterile area. 9. Non-sterile person keep away from your sterile area. 10th, sterile person keep in contact with sterile area to a minimum. 11. Moisture may cause contamination. And 12th, when bacteria cannot be eliminated from a field, they can be reduced to a minimum. After your patient is wheeled in on the OR bed, as a circulator, you have to position the client properly. So these are the factors that will determine the type of your position, determined by the operative procedure. So don't worry, we will also have a discussion on the common position for a certain surgery, the surgical approach, and then also the kind of anesthesia to be given, the age, the weight, and the height also of the patient, plus the patient's general conditions. Now, what are the equipment needed for positioning a client? We have your operating table, footboard, blankets, arm board, arm straps, pressure mattress, pillows, stirrups, table extension, and your anesthesia machine. So what are the general considerations and rule of safety in your positioning? Explain to the person in simple and understandable terms. So, gumamit ng terms na naayon sa level of understanding ng ating patient. Preserve the patient's dignity and avoid undue exposure. Strap the persons to the table with well-padded straps. It has not to be too tight and not too loose to prevent now your nerve and tissue damage. Maintain adequate respiratory exchange and vascular circulation. You do not allow the patient's extremities to dangle over the sides of the OR table, as this may impair your circulation or cause your nerve or muscle damage. Now, avoid excessive strains on the person's muscles and be certain that the person's body does not rest on hands or fingers, otherwise your circulation may be occluded. Common surgical positions and operative procedures. Sa supine, we usually use this for your CS, gastrectomy, Billroth 1 and 2, mastectomy. For the dorsal recumbent naman, hernia repair or bowel resection. For the lithotomy, we use this for vaginal repairs, episiotomy, colporrhaphy, rectal surgeries such as your hemorrhoidectomy. For the lateral, nephrectomy, nephrolithotomy, thoracotomy, thoracostomy, hip replacement, and your hip repair. For our Trendelenburg, we have your thoracostomy and cholecystectomy. Moderate Trendelenburg naman for our thyroidectomy. This is now used to displace the organ. Our nursing responsibilities during positioning is that maintain a good respiratory function, maintaining of your good circulation, prevention of the pressure on the muscles and nerves, good exposure and accessibility of the operative field, and a good access for the administration of anesthetic and observation of the effects. After our positioning of the patient, we also have to do our skin preparation or our skin painting. Now, the purpose of your skin preparation is to render the skin as clean and free of bacteria as possible without causing your irritation or damage to the skin. and without impairing its natural protective function and without interfering with your subsequent wound healing. So, yung sinasabi niyang bacteria dito, pareha, is your normal flora or your resident bacteria. Our aim here is for the numbers to decrease, and for the transient bacteria is to be removed by your scrubbing. So, dalawa ang ating skin preparation during the paggagamit ng regional block or conduction block or spinal anesthesia ang patient. We will also do our skin preparation. Tapos, iba pa ulit ang skin preparation natin during your surgical operation. Materials used in skin preparation. We have our sterile gloves, antiseptic solution, betadine, povidone iodine, 10% yata to pag hindi ako nagkakamali. And then kidney basin, waste paper basket, hydrogen peroxide, pick-up forceps, prep table placed on a Mayo stand, and a prep balls or your cherry balls. Baka nagtataka kayo kung bakit iba na ang gamit dito. They are using already a chlorhexidine plus a povidone iodine dito sa slide. Okay? Now, guidelines in your skin preparation. Before proceeding to any skin preparation, the nurse should know the following: that all essential materials are available, the kind of preparation to be done, how to help the surgeon in positioning the patient, the outer boundaries of the skin preparation area, how to recognize an allergic reaction and steps to be taken if reaction occurs. Second, the duration of the skin preparation is usually 5 minutes but may be longer or shorter depending on the size of the area to be operated. New sponges must be used when returning to the incision site. Nurse should be extra careful not to contaminate the sterile gloves by touching anything but the skin that is being prepared. Skin preparation should be done with firm but not rough movements. The nurse should observe the patient's skin for any reaction to the antiseptic solution and the procedure. The operative area should be washed thoroughly at least 4 times, and draping of the operative area is done immediately after the skin preparation. So this slide will show you kung ano yung dapat na areas of skin, not skin yan, hair removal and skin preparation. So, depende sa magiging incision site or sa procedure to be done. Kung mapapansin nyo, we have still our circular, pero mas malaki na ang area of ating pinipaintan. So, let's say dito lang ang incision, kailangan buo na yan ang ating i-prepare. So, these are your examples for your hair removal and skin preparation. Sedation and anesthesia. So, pag ang ating patient is to undergo a surgical procedure or an operation, we would anticipate the patient will need a sedation, anesthesia, or a combination of these. So, what are the purpose of the administration of your anesthesia? For muscle relaxation, analgesia or insensitivity to pain, temporary amnesia, sedation or artificial sleep, and to render temporary unconsciousness. There are different types of sedation. We have your minimal sedation, moderate sedation, and deep sedation. For our minimal sedation, it is where a drug-induced state during which the patient can respond normally to your verbal commands. Cognitive functions and coordinations may be impaired, but ventilatory and cardiovascular functions are not affected. While on your moderate sedation, it is a form of anesthesia that may be produced intravenously. It is defined as a depressed level of your consciousness that does not impair the patient's ability to maintain a patient airway and to respond appropriately to physical stimulation and verbal command. Ang goal nitong moderate sedation natin is a calm, tranquil, amnesic patient who, when sedation is combined with your analgesic agent, is relatively pain-free during the procedure, but also able to maintain your protective reflexes. Example of your moderate sedations are your midazolam or your diazepam. Siya yung ginagamit frequently for your intravenous sedation. Now, sino ang pwedeng mag-administer nitong ating for our moderate sedation? Pwede ang ating anesthesiologists or anesthetists, our physicians, pwede din ang nurse. Kailangan knowledgeable yung nurse kung siya ang mag-administer nitong mga to. So, pag ikaw na nurse ang request to administer this medication, you have to be skilled in detecting dysrhythmia and administer also oxygen, tapos perform resuscitation continuously, and then monitor the patient who receives the sedation. Your moderate sedation now may be used alone or in combination with your local, regional, or your spinal anesthesia. While on your deep sedation naman, it is a drug-induced state during which a patient cannot be easily aroused but can respond purposely after repeated stimulation. Ang difference nila with your anesthetized na patient is that pag anesthetized na ang patient, hindi na siya nagigising. Non-arousable siya kahit deep stimulation. Your deep sedation and your anesthesia is achieved when an anesthetic agent is inhaled or administered intravenously. For your inhaled anesthetic agent, it would include your volatile liquid agent and gases. Your volatile liquid anesthetics produces your anesthesia when the vapor is inhaled. Now, included in this group are your halothane or your fluothane, enflurane or ethane, isoflurane or furane, sevoflurane or ultrane, and your desflurane or suprane. All are administered with oxygen, usually with your nitrous oxide as well. Your nitrous oxide is the most commonly used gas anesthetic. So, pag na-inhale na yon, the agent will enter the blood through your pulmonary capillaries and it will act on your cerebral centers to produce a loss of consciousness and sensation. Pag na-discontinue naman tong anesthetic natin through your inhalation administration, the vapor or the gas is now eliminated through your lungs. Now let's go to your general anesthesia. It consists of your 4 stages, each associated with your specific clinical manifestation, and when opioid agents or a narcotic and neuromuscular blockers such as your relaxants are administered, several of the stage will be absent. So your anesthesia is a state of narcosis, severe central nervous system depression produced by a pharmacologic agent. Analgesia, relaxation, and reflex loss. Your patient now under general anesthesia are not arousable even to your painful stimuli. They lose the ability to maintain your ventilatory function and they require assistance in maintaining a patent airway. Your cardiovascular functions may be impaired as well. For the stage 1 or the beginning anesthesia, at this stage, your patient breathes in the anesthetic mixture. Warmth, dizziness, and a feeling of detachment may be experienced. The patient may have also a ringing, roaring, or buzzing in the ears, and those still conscious may sense an inability to move the extremities easily. Sa stage na to, noises are exaggerated even in low voices or minor sounds may seem loud and unreal. So, because of this reason, nurses should avoid making unnecessary noises or motions when the anesthesia now begins. Second stage is your excitement. when we say excitement stage, it is characterized variously by struggling, shouting, talking, singing, laughing, or crying is oftenly avoided if the anesthetic is administered smoothly and quickly. So now the pupils now will dilate, but it contract if exposed to light. Pulse rate also is rapid and may have a irregular respiration. Because of this possibility of uncontrolled movements of the patient during this stage, yung ating anesthesiologist will need someone to assist him or her to help restrain the patient. So, kailangan na minsan ng strap to put in place yung patient's thigh, and the hand has to be secured to the armboard. The patient now should not be touched except for purpose of restraints, but your restraint should not be applied over the operative site. So manipulation increases your circulation to the operative site and thereby increases the potential for your bleeding. Let's go to your stage 3, which is your surgical anesthesia. It is reached by continued administration of the anesthetic vapor or a gas. Now, your patient is unconscious and lies quietly on the table. The pupils are small but contracts when exposed to light. Your respiration is regular. The pulse rate and the volume are normal, and the skin is pink or slightly flushed. With proper administration of your anesthetic, this stage may be maintained for hours in one of several planes, ranging from light to your deep, depending on the depth of your anesthesia needed. For your stage 4 or your medullary depression, at this stage, ito yung ayaw nating ma-reach out when we have your patient anesthetized. Because your respiration now becomes shallow, we also have a weak pulse and thready. Your pupils now become widely dilated and no longer contract when exposed to light. Development also of cyanosis, and without prompt intervention, death would rapidly follows. If this stage develop, the anesthetic is discontinued immediately and respiratory and circulatory support is initiated to prevent your death. Stimulants, although rarely used, may be administered, and a narcotic antagonist can be used if overdosage is due to your opioids. So during the smooth administration of your anesthetic, there should be no sharp division sa first 3 stages natin, which is the beginning, the excitement, and the surgical anesthesia. Your patient now will pass gradually from one stage to another, and it is only by your close observation will see the signs be exhibited by your patient. So the anesthesiologist or anesthetist controls the situation. Now, the responses of the pupils, the blood pressure, and the respiratory and cardiac rates are probably the most reliable guides to the patient's conditions. Methods of your anesthesia administration. First is your inhalation. Now, liquid anesthetics will be administered by the mixture of your vapor with oxygen, or pwedeng nitrous oxide, oxygen, and then have the patient now inhale the mixture. There are 3 ways on how we will administer your inhalation. First is your GA by mask or your general anesthesia by mask. We also have our GA by LMA or your general anesthesia by your laryngeal mask anesthesia. Now, if we are to use your laryngeal mask, it is a flexible tube with an inflatable silicone ring and a cuff that can be inserted into the larynx. Then we also have our GETA or your GETA, general endotracheal anesthesia. Ito naman, mag-i-insert ang ating anesthesiologist ng endotracheal tube using your the tube now will seal off the lungs from the esophagus. So if ever the patient will vomit, yung stomach contents will not enter your lungs. Second, we have our intravenous. Your general anesthesia can also be produced by the intravenous injection of various substances. Example here are your barbiturates, benzodiazepine, non-barbiturate hypnotics, dissociative agents, and your opioid agents. Now, these IV meds will be administered for an initiation or during the induction of your anesthetic or anesthesia, and then or pwede din for maintenance of your anesthesia. Pwede siyang gamitin kasama ng inhalation or it can be used alone. So, pwede lang na intravenous anesthesia lang siya. Then, the onset of your anesthesia is very pleasant. Wala siyang buzzing, roaring, or dizziness na common na nakikita natin if your patient undergoes your inhalation anesthesia. Now, the duration of the action is very brief and your patient will awakes. Gigising yung patient mo with little nausea or vomiting. Now, ang ating agent of choice for your intravenous is your thiopental. It is often administered with other anesthetic agents in a prolonged procedure. So, our intravenous anesthetic agents, they are non-explosive and they also require little equipment and they are easy to administer. Kailan ginagamit usually ang ating intravenous anesthetic agent? They are used for your short procedures, pero it is used less often for a longer procedures such as your abdominal surgery. It is not also indicated for your children who have small veins and require intubation because of their susceptibility to your respiratory obstruction. Ang disadvantage ng ating intravenous anesthesia is that such as our thiopental, it is a powerful respiratory depressant. And also, sneezing, coughing, and laryngospasm are sometimes noted with its use. Kasama nito are under your intravenous anesthesia is your intravenous neuromuscular blockers or our muscle relaxants. Now, they block the transmission of your nerve impulse at the neuromuscular junction of the skeletal muscles. So, sa word itself, it relaxes the muscles during your abdominal and thoracic surgery. It also relaxes the eye muscles in certain types of your eye surgery. It also facilitates your endotracheal intubation and to treat your laryngospasm, and it would also assist in your mechanical ventilation. The first widely used muscle relaxant is your purified Curer, and the active ingredients is your tubocurarine. And your succinylcholine was later introduced because it acts more rapidly than your Curer. Now, if you are looking for an ideal muscle relaxant, it has to have this following characteristic. It is non-depolarizing or a non-competitive agent with an onset and duration of action similar to your succinylcholine but without its problem of bradycardia and cardiac dysrhythmias. Second, it has a duration of action between those of succinylcholine and pancuronium. It also has to lack cumulative and cardiovascular effect. And the last, it can be metabolized and it should not depend on the kidneys for its elimination. Third, we have our regional anesthesia. It is a form of your local anesthesia in which an anesthetic agent is injected around nerves so that the area supplied by these nerves is anesthetized. The effect depends on the type of nerve involved. Now, these are agents that will block the nerve impulse at its origin along afferent neurons and along your spinal cord. So, an anesthetic cannot be regarded as having worn off until all your three system, ano itong three system na sinasabi natin? We have our motor, sensory, and autonomic are no longer affected. So, as long as na-affect ang tatlong system natin, hindi natin pwedeng sabihin na nag-worn off na yung regional anesthesia natin. So, a patient receiving your spinal or local anesthesia is awake. So, aware siya sa kanyang surroundings. So, unless a medication will be given to produce a mild sedation or kung to relieve your anxiety, tayong mga nurse must avoid a careless conversation now. Avoid also unnecessary noise and unpleasant odors. This may be noticed kasi by the patient since the patient is awake. So, pag may mga narinig siya or medyo nagkaroon siya ng unpleasant na experience during sa kanyang operation, then this will give the patient a negative view of the surgical experience. Now, provide a quiet environment so it will be a therapeutic to the patient. And kung if a diagnosis is to be done, wag isasabihin aloud kasi the patient may know at that time kasi nga gising yung patient natin. Conduction blocks and spinal anesthesia. This may be subarachnoid block, epidural block, and your spinal anesthesia. They are commonly used for your CS, hysterectomy, appendectomy, and any abdominal surgery or amputation. For your epidural anesthesia, the injection of your local anesthetic is into the spinal canal in the space surrounding your dura mater. Your epidural anesthetic will now block your sensory, motor, and your autonomic function. Now, the advantage of your epidural anesthesia is the absence of headache, which is commonly a result of your subarachnoid injection. Ang disadvantage lang nito is that it is a challenge that na-introduce yung anesthetic into the epidural rather than your subarachnoid space. Pag nagkaroon ng inadvertent injection sa subarachnoid, sa halip na epidural yung mode mo, then the anesthetic agent now will travel towards the head and a high spinal anesthesia can result. This will now produce a severe hypotension and respiratory depression and possible arrest. So, ano ang treatment of this complication? It will include your airway support, intravenous fluid, and the use of your vasopressor. Other types of your nerve blocks include your brachial plexus block. This will now produce anesthesia on the arms. Paravertebral anesthesia, which is produces anesthesia of the nerve supplying the chest, abdominal wall, and extremities. We also have your transsacral or your caudal block, which produces your anesthesia of the perineum and occasionally your lower abdomen. Pag sinabi naman nating spinal anesthesia, it provides regions of anesthesia from the abdomen to the toes. So it is a type of extensive conduction nerve block that is produced when a local anesthetic is introduced into the subarachnoid space and the lumbar level. Usually na ginagamit is your L4 and your L5. So the spread of your anesthetic agent and the level of your anesthesia will depend on the amount of your fluid injected, the speed with which it is injected, the positioning of the patient after the injection, and the specific gravity of the agent. So, sa spinal anesthesia, you have to assist the anesthesiologists to position the patient in a knee chest position. Ano yung mga general agents na ginagamit for your conduction blocks and spinal anesthesia? We have our procaine, tetracaine, pontocaine, and of course our lidocaine and or xylocaine and your bupivacaine. So, after a few minutes na na-induct ang ating spinal anesthetic, your anesthesia now will have a paralysis effect on your toes, up to your perineum, and then gradually the legs and the abdomen. If the anesthetic reaches the upper thoracic and cervical spinal cord, ibig sabihin nun, high concentration and a temporary partial or complete respiratory paralysis ang maging result nun. So, pag nagkaroon ng paralysis of the respiratory muscles, it is managed through your mechanical ventilation until the effect of your anesthetic on the respiratory nerves have worn off. Nausea, vomiting, and pain may occur during your surgery when your spinal anesthesia is used. So, as a rule, this reaction now will result from the manipulation of various structures, particularly those with the abdominal cavity. Headache is the after effect of your spinal anesthesia, and there are several factors that are involved why an incidence of headache will happen. So, the size of the spinal needle used, pwedeng dahil doon, or the leakage of fluid from the subarachnoid space through the puncture site, and of course, the patient's hydration status. Now, measures that increases your cerebrospinal pressure are very helpful now in increasing or in relieving your headache. Ano ang mga example nito? Keeping the patient now lying flat and producing a quiet environment plus hydrate the patient. For a continuous spinal anesthesia, we have our CEA or continuous epidural anesthesia. It is where your catheter is inserted into this epidural space and it will remain in the subarachnoid space during your surgical procedure so that more anesthetics may be injected as needed. Now, this technique will allow greater control of the dosage, but there is greater potential for post-anesthetic headaches because of the large gauge needle use. Last, we have your local infiltration anesthesia. The advantages of your local anesthesia is that it is simple, economical, and it is non-explosive. Second, the equipments needed is minimal. Post-operative recovery is brief, and an undesirable effect of your general anesthesia are avoided. It is also ideal for your short, superficial surgical procedure. Your anesthetic agent is injected into a specific area at the operative site, and it will interfere now with your impulses from the CNS to the operative site while your tissues are being manipulated. Your local anesthesia is often administered in combination with epinephrine because epinephrine now constricts your blood vessels, which now prevents rapid absorption of the anesthetic agents, and thus it prolongs its local action. If a rapid absorption of the anesthetic agents into the bloodstream will cause now a seizure, and it will be prevented. So, local anesthesia is the anesthesia of choice in any surgical procedure in which it can be used. Contraindication nito is include your high preoperative level of anxiety because your surgery now with local anesthesia may increase anxiety. The skin is prepared for any surgical procedure, and a small gauge needle is used to inject a modest amount of the anesthetic into the skin layers. Now, this will produce blanching or a wheal, and additional anesthetic is then injected in the skin until an area, the length of the proposed incision, is anesthetized. The action of the agent is almost immediate, and your surgery may begin as soon as the injection is completed. So, your local anesthesia will last 45 minutes to 3 hours depending on the anesthetic and the use of epinephrine. Most common incision sites. First is our kosher or Coker incision, also known as your subcostal incision. It is an incision on the right side of the abdomen used for open exposure of the gallbladder and your biliary tree. This incision is just inferior and parallel to the subcostal margin. Now, this type of incision is associated with a slight increase in pain during the post-operative phase due to the severing of your rectus muscle. Next is our midline incision. Our midline incision is also known as the laparotomy incision or your ciliotomy, and the most traditional of all surgical incisions. The sizes may vary depending on the types of procedure to be performed, but your midline incision may be small and applied anywhere in the vertical linea alba. This incision is will generally provide the best visualization and intra-abdominal access, commonly used for your exploratory procedure and trauma. Third, we have our McBurney's incision or our gridiron incision. It provides a good exposure for performing your open appendectomies and is made obliquely at the McBurney point, 2/3 from the umbilicus to the anterior superior iliac spine. So, this is for your appendectomies. Fourth, we have our battle incision or also known as your battle Jolacare Kammerer Lenander incision. It is a lower right paramedian incision but placed more laterally than the standard paramedian incision. It is suitable for dealing with your acute appendicitis and pathologies in the right lower quadrant of the abdomen. Fifth, we have our lance incision or also known as your Rocky Davis. Your lance incision is similar to your gridiron incision and is useful for open appendectomies. It is made at the McBurney's point with the same anatomical layers as well as the blood supply. However, your lance incision now is a horizontal incision while the gridiron incision is an oblique angle. 6, we have our paramedian incision. With our paramedian, pwede siyang maging lateral paramedian or medial paramedian. It is a surgical incision, especially of the abdominal wall close to the midline. Next incision, we have our transverse incision or also known as your clamshell incision. It is a large transverse incision that spans across the entire chest wall and also known as a bilateral thoracotomy and is used during massive chest trauma, lung transplant, or resection of tumors in the chest. This incision now extends through the sternum between the 4th and 5th ribs bilaterally and extends to the mid-axillary line. Number 8 is your Rutherford-Morrison incision. Your Rutherford-Morrison incision is for the access to your sigmoid colon and pelvis, particularly used if the midline is very scarred from your previous surgery. Last, we have our Fanen-style incision. Your Fanen-style incision is also known as your low transverse incision or pwede din siyang curve incision, pubic incision, and your bikini cut. So, Fanen-style is a transverse lower abdominal incision that is made superior to the pubic ridge. This approach is most frequently used for your urologic, orthopedic, pelvic, and cesarean sections. Now, the major drawback of this incision is it limits the exposure beyond the pelvis. And the blood supply to keep in mind is the inferior epigastric branches as well as the superficial epigastric. Intraoperative care. Number 1, you protect the patient from any injury. Skin care during transfers. Place and maintain comfortable position, and it has to be padded as required. Now use your safety devices such as your side rails and your safety straps. Protect from infection hazards. Use only sterilized packs and instruments. Number 3, preparation and coordination of the circulating for smooth procedure, assisting and scrubbing functions. So under your preparation, we have your counting of sponges, serving of instrument, and ensure and provide warm fluids, adequate lighting, and keep things easily accessible. Number 4 is to monitor your physiologic responses. For the general anesthesia, it will be your anesthesiologist who will monitor. For the local anesthesia, it will be the nurses. Now maintain accurate and complete documentation. Potential intraoperative complication, una dito is our nausea and vomiting or regurgitations. So this may affect your patient during the intraoperative period. If it occurs with gagging, then the patient is turned to the side and the head of the table is lowered, and a basin is provided to collect the vomitus. Your suction is used to remove your saliva and vomited gastric contents. Now, the anesthesiologist may administer your antiemetics preoperatively or intraoperatively to counteract your possible aspiration. Now, if the patient aspirates the vomitus, ano ang ating makikita if the patient has an aspiration of the vomitus? There will be an asthma-like attack with a severe bronchial spasm and wheezing. So, pneumonitis and pulmonary edema can subsequently develop, leading to your extreme hypoxia. Increasing your medical attention is being paid to silent regurgitation of your gastric contents, which occurs more frequently than previously realized. Second is your anaphylaxis. Dahil may mga medications tayong binibigay sa patient intraoperatively, meron talagang magkakaroon ng anaphylactic reaction. So, intraoperatively, the nurse must be aware of the type and the method of anesthesia used, as well as the specific agents. An anaphylactic reaction can occur in response to many medications, pwede rin sa latex or other substances. Now, the reaction may be immediate or delayed. Anaphylaxis is a life-threatening and acute allergic reaction that causes your vasodilation, hypotension, and bronchial constrictions. Meron kasi din sa ating surgical procedures na hindi na gumagamit ng ating suture to close the wounds. They use your fibrin sealants. Now, these sealants have been implicated in allergic reactions and anaphylaxis. Although these reactions are rare, the nurse should be alert to the possibility and observe the patient for changes in vital signs and symptoms of your anaphylaxis when these products are used. Third is your hypoxia and other respiratory complications. Inadequate ventilation, occlusion of the airway, inadvertent intubation of the esophagus, and hypoxia are your significant potential problems of general anesthesias. Madaming factors na nagko-contribute sa inadequate ventilation. Your respiratory depression naman can be caused by your anesthetic agents, aspiration of the respiratory tract secretions or the vomitus, and also the patient's position on the operating table can compromise now the exchange of gases. In addition to those dangers, meron din tayong asphyxia which is caused by your foreign bodies in the mouth, pwede ring spasm of the vocal cords, relaxation of the tongue, kaya tayo naglalagay din ng tongue guard minsan, or aspiration of your vomitus, saliva, or blood may occur. Since brain damage occurs pag merong hypoxia, we have to be more vigilant in assessing the patient's oxygenation status. So, eto naman pag-assess for the oxygenation is the primary function of your anesthesiologist or anesthetist and your circulating nurse. Now, peripheral perfusion is checked frequently, and of course, pulse oximetry values are monitored continuously. Hypothermia, it is during your anesthesia where the patient's temperature may fall. Glucose metabolism is reduced, and as a result, your metabolic acidosis may develop. Now, this is called your hypothermia, and it is indicated by a core body temperature below normal, so 36.6 or lower. Inadvertent hypothermia may occur as a result of a lower temperature in the OR, infusion of your cold fluids, inhalation of the cold gases, open body wounds or cavities, decreased muscle activity, advanced age, or the pharmaceutical agents such as your vasodilators, phenothiazines, and your general anesthetics. Hyperthermia may also be intentionally induced in selected surgical procedures such as your cardiac surgeries that requires your cardiopulmonary bypass to reduce the patient's metabolic rate. Now, if it's an unintentional hypothermia, our main goal of intervention is to minimize or reverse the physiologic process. If your hypothermia naman is intentional kasi nag-undergo siya ng cardiopulmonary bypass, then the goal is for the safe return to your normal body temperature. Your environmental temperature in the OR can be temporarily set to your 25 degree to 26.6 degrees Celsius, and then intravenous and irrigating fluids will be warmed. Your wet gowns and drapes now has to be removed promptly and replaced with your dry materials because your wet linens now promote heat loss. Whatever methods are used to rewarm the patient, warming must be accomplished gradually and not rapidly. Now, conscientious monitoring of your core temperature, urinary output, ECG, blood pressure, arterial blood gas levels, and your serum electrolyte levels is required. For our malignant hyperthermia naman, is an inherited muscle disorder chemically induced by your anesthetic agents. Identifying patients at risk for malignant hyperthermia is imperative. Your susceptible people include those with strong and bulky muscles, a history of muscle cramps or muscle weakness, and unexplained temperature elevation, and an unexplained death of a family member during surgery that was accompanied by a febrile response. So, ang brief pathophysiology nito is that during the anesthesia, the potent agents such as your inhalation anesthetics and muscle relaxants may trigger the symptoms of your malignant hyperthermia. Plus, the stress and some medications such as your sympathomimetics, theophylline, aminophylline, and anticholinergics and cardiac glycosides can induce also or i-intensify pa niya yung reaction as well. It is related to your muscle cell activity, and then your calcium, an essential factor in muscle contraction, is normally stored in your sacs in the sarcoplasm. So when nerve impulses stimulate the muscles, your calcium now is released, allowing contraction to occur, and a pumping mechanism now returns your calcium to the sac so that the muscle can relax. Now, in malignant hyperthermia, this mechanism is now disrupted. Your calcium ions are not returned and they accumulate, causing your clinical symptoms of your hypermetabolism, which in turn increases your muscle contraction or the rigidity, hyperthermia, and the damage to your central nervous system. Initial symptoms of your malignant hyperthermia are related to your cardiovascular and your musculoskeletal activity. So, meron tayong tachycardia, which your heart rate is above 150 beats per minute. Ito yung pinaka-earliest sign natin. In addition to this, we also have our sympathetic nervous stimulation, which leads to your ventricular dysrhythmia, hypotension, decreased cardiac output, oliguria, and later your cardiac arrest. With the abnormal transport of your calcium, rigidity or tetanus-like movement may occur often in the jaw. So the rise in your temperature is actually a late sign that develops rapidly, and the body temperature can increase 1 degree to 2 degrees Celsius every 5 minutes. The temperature can reach or exceed 40 degrees Celsius in a very short time. Medical management for our malignant hyperthermia is, of course, we should recognize the symptoms as early as possible and discontinue the anesthesia promptly and imperative. Now, goal of treatment is to decrease your metabolism, reverse yung metabolic and respiratory acidosis, correct your dysrhythmias, decrease your body temperature, provide oxygen and nutrition to your tissues, and then correct your electrolyte imbalance. So a treatment protocol should be posted in the OR or be readily available in a malignant hyperthermia cart. Although this malignant hyperthermia usually presents about 10 to 20 minutes after the induction of anesthesia, it can also occur in the first 24 hours after surgery. As soon as the diagnosis is made, your anesthesiologist and your surgeon will halt the procedure and the patient is hyperventilated with 100% oxygen. Dantrolene sodium, a skeletal muscle relaxant, and sodium bicarbonate are administered immediately. So, continued monitoring of all parameters is necessary to evaluate the patient's status. Nursing management natin, if a malignant hyperthermia occurs, the nurse must identify the patient at risk and recognize the signs and symptoms, and also have the appropriate medication and equipment available, plus be knowledgeable about the protocol to follow. Our last potential intraoperative complication is our disseminated intravascular coagulopathy, or your DIC. It is a life-threatening condition characterized by a thrombus formation and the depletion of your select coagulation proteins. Now, the predisposing factors includes many conditions that may occur with your emergency surgery, such as massive trauma, head injury, massive transfusion, liver or kidney involvement, embolic events, or shock.